So we're coming to the end of the day. We're still going to cover some tricky parts in some ways because this is what everybody's talking about. This is actually also what my research lab is doing a lot nowadays, because when you look at some of it, there's quite a lot going on. But to me, I want to come back to what I showed you before. It's like our really clinical question is, can we distinguish these patients, which are very different based on etiology, but very kind of similar at first presentation when we start to look at the images, all with regard to their presentation in the hospital and so on. So the question is, can we do this better? Because what I try to explain you is like when you integrate all the information, you look at the deformation in whatever way, you combine that with the knowledge of the physiology and so on. So what we need to do is try to recognize these patterns in some ways. And so I'm mostly interested in, can we do this more automatically? Because I've been talking about this hypertrophy for a couple of years, well, maybe 10 years or even longer. And still a lot of people find this rather difficult because you need to be able to do the strain properly. You need to have it on your machine. You need to be able to kind of interpret it in the right way. So there's still a lot of things that makes in clinical practice, or you need to have time, for example, also to do it. So that makes it difficult. And at the same time, also what we need to do is just also compare it with integrated information, for example, from Doppler. When you look at Liv Hadley, maybe I hope still some people remember her, the young people unfortunately not, but she's the one that started with the pressure gradients based on Doppler, of course. And what she always did is, when you look at her slides, is she takes Dopplers and she puts them underneath each other and time aligns, and stretches it a little bit and time aligns. So this is something which is physiologically extremely relevant, because you want to know what's happening at the left side, at the right side, at the inflow and the outflow, and see how these relate to each other, because that gives you insight, especially, for example, in filling. But this is not straightforward. And on the other hand also, it's like this is not what the companies want to do. So we don't have tools to do that. It is physiologically extremely relevant, but it's not sexy. So companies are not going to sell machines based on this. So the question is, can we somehow provide ways that companies will somehow put this into their systems? And I think this is something that I'm quite interested in. But on the other hand also, we've been talking a lot about strain here, but also when you saw George's cases and when you see a clinical patient, I mean, you don't look only at the echo, definitely not only at the strain. You need all the other clinical information. You need to integrate it with the ECG, with the lab values, with what you see of the patients, potentially some text or reports from previous hospitalizations or things like that. So we need to also find ways to take that easily into account and as natural as possible in some ways. And what I think is also very interesting is like we have to check what we're not good at, because that's what we need to improve. I told you before, we're not good at this training and knowing, at recognizing this, at changing things, especially if it takes more time. But even if you look at our standardized way of working, when you look at the problems, for example, in wrong diagnosis based on imaging, what you see there is that what happens quite a lot is an under-interpretation of the findings. The other problem is incorrect or technical problems. So all of these are in a way that, because we are trained to recognize something, and I have to admit, in places where they use technicians to do echoes, they're actually better at this because they follow a very protocolized way of looking at things. When cardiologists are doing it, and especially when they don't have a lot of time, what they do is they put on the probe, they see, there's an aortic stenosis, I'm going to measure this, and I forget about it. You forgot about something else going on, or some right ventricular problem, or problem here. So you're under-interpreting because you're recognizing something and you say, okay, this is it, without thinking too much. And this is one of the big problems. And the reason for that is actually when you start looking at how we make decisions, actually our brain has two ways to make decisions. Type 1 and type 2, some people have been calling this. One is we are extremely good at pattern recognition, because this is what you need when a lion comes to you and you have to run away. You immediately have to see danger without thinking. So we see this. You see, for example, I see an aortic stenosis. I don't need to do anything else because I recognized it. That's it. So this is our fast way of doing it. But of course, that's error-prone because we don't think about it. The other way is doing it slowly and saying like, okay, I'm going to measure all these things. I'm going to take all the views. I'm going to think about my physiology. And then you don't forget anything. But of course, this is much more energy consuming. This takes a lot longer. But it might be relevant in some ways. And especially I like a couple of studies that some people did in radiology. And here they took chest x-rays and they embedded a gorilla, so literally an image of a gorilla in the chest, so in the lungs, in the X-ray. And then they asked, look for nodules. And then the radiologists were kind of looking at it, and 80% or more of radiologists didn't see that there was a gorilla. This gorilla that you see there, which you cannot miss, but 80% missed it. Why? Because, well, they're not trained to recognize gorillas. They're trained to look at lung nodules. So if you don't use and don't think, then you can miss this. And another interesting one where they tried both ways is, so here you see chest x-rays with a missing clavicula. So if they said, again, the radiologist, like, look at this chest x-ray for lung nodules, most of them missed the fact that the clavicula was missing. But if they told them, like, look, we have this new drug and it does something in the lungs, but we actually don't know what, make sure nothing is wrong, then almost everybody saw, look, there's a clavicula missing. So you see, you switch from one way of thinking to the other. And this is really, really relevant when we start to look at artificial intelligence. So actually, artificial intelligence is a bunch of methods. Even robotics is part of artificial intelligence. Most of the things that we talk about is actually machine learning, where we try to train the machine to recognize something. And what is the most common now, or what most people kind of say that artificial intelligence even would be, is called deep learning. And this is actually artificial neural networks. So this is what Google, Apple, Facebook, and so on are all doing. They kind of try to recreate a brain, so a lot of neural interconnected cells in a computer. But of course, this is the way our brain works functionally in this way of rapid recognition. So what you do is you replicate our way of quickly recognizing something. That can be very, very powerful, but it's also very dangerous because, as I said, even our brain can miss if we don't use the right way of thinking about it. And these neural networks, they're actually really, really powerful. So what people have been showing is like things that people said the computer can never do is win, for example, in this game Go, is like, but the computer has done it. Currently, computers are better in interpretive reading than kids of certain ages. You see the current robotics, they are almost replicating humans. And all of this is actually using artificial intelligence, but deep learning. Exactly this, artificial neural networks. And so when you look at the images and when you look at Google and you do these searches and when Facebook or Apple recognizes your friends on your pictures, this is what they do. They try to put labels on what they say. They try to recognize things, try to recognize a hat, an orange, try to recognize Elisa on images from wherever they come. And they're actually quite good at it, and it gets better and better. But actually, when we start to use this for medicine, this was actually a really interesting study where they trained pigeons to recognize malignancies on histological images, and they compared it to an artificial neural network like Google and so on. And actually, the pigeons are doing better than artificial intelligence in recognizing malignancies. But this is, of course, because what you do is you replicate this recognition. And obviously, pigeons have a brain, and still the pigeon brain is much better than what we can recreate in the computer. We try to recreate the brain in the computer, but the computer brain is still kind of much, much less and much stupider than a pigeon is. So the question is, are we going to change our echocardiography people with pigeons? Well, probably not. So this is to me really important that you understand what you replicate with some techniques. And so you can now, and that's what you've been seeing, and this is what most of the studies about this kind of machine learning, artificial intelligence, and imaging go about. It's like that you do, that your computer is taking over your diagnostics. And you actually, when it's pattern recognition that you can train, it's super powerful. And it's just, of course, it's easier because you don't have to do it, so it's cheaper, it's faster, and you can really train them. And so here, for example, this was COVID cases, you train on this, and you say, okay, this works very well. The problem is that if you give something that you haven't trained for, obviously it totally goes wrong. Because here the system says that if you give this image to the system, it says, this is COVID, this is a patient with COVID. Obviously it's not, but what it is something which is dark on the inside, a bit light around it, and which is darker than a normal chest X-ray. So this is what you recognize. So it's really important that you train for what you want to look for. And here's another example. So these things are very good at distinguishing difficult things, but actually still, humans are still a little bit better. But the problem is if you're going to use this for your diagnosis, like, of course, here it doesn't matter that the system says that this muffin is a chihuahua, or the other way around, that this chihuahua is a cupcake. I mean, this is fun. And when it's Google, it doesn't matter. Well, actually, it does matter. I don't know whether you ever heard about this kind of scandal in Google, where so Google puts labels on this, and they were looking at the label gorilla, and actually they labeled a lot of black women as gorilla, which is, of course, a big scandal. So especially in the US, I mean, this is not done. Then Google kind of said, okay, let's find a way to improve this. They worked 1 year of it, and the conclusion was that they had to remove the label gorilla because they were not able to distinguish it in some ways. So these artificial brains are still not good enough to do many of these things. And so be very careful when you start using this then for medicine on what you get from it or what kind of conclusions you take from it. And here's another kind of, well, two other very, very interesting examples. I like this one quite a lot because this shows you that analyzing Twitter is as good as a cardiologist. So with analyzing tweets of people, you can actually predict if they're going to die from cardiovascular disease, yes or not. It's like, come on, I mean, you're not going to use the Twitter account of your patient in order to diagnose them. But when you start thinking about it, there's obviously an association between Twitter of people and cardiovascular diseases. Because if people are kind of tweeting like, oh, I went to McDonald's for the 3rd time this year and I smoked 5 packs of cigarettes today and I have an appointment with my cardiologist tomorrow, then you know that they are much higher cardiovascular risk than something else. So these are associations and not necessarily kind of causal link. So we have to be very, very careful about it. Similarly, with COVID, there's of course people tweeting about COVID. There you will have more cases of COVID. So this is these things you have to always keep in mind. And another thing that is also, is like, as I said before, these things need to be trained with something you know, and you have to look for this. But you have to keep in mind, and this is especially here very, very important, that there's a huge difference between data that is very, very good that we have at our disposal, which is mainly from trials and kind of clinical studies, versus clinical routine. Because the data from trials, we know, have very limited inclusion criteria. They have very specific imaging protocols. They have very strict protocols on treatment. And very, very importantly, they have very strict timings. So that means that this is very clean data. If you train a network on this, you're going to be extremely good to predict trials. But of course, when you look at clinical practice, a patient comes with symptoms, but they come with different symptoms. They come at different stages of their disease. Depending on where you go in the hospital, they will do different things. They will do different imaging. I mean, you look at strain differently than you would look at strain. So there's so many differences. Then you do some decision making, which is based on guidelines, but everybody knows guidelines might be crap sometimes. So everybody uses the guidelines in their own way in some ways. And what is very, very important is that the timing is very different. So it could be that your patient comes back sooner or later. It's not like you have this strict follow-up as in clinical studies. So that means that whatever you train here, where we have good training data, doesn't work here in clinical practice, but we don't have good training data for that. Because still, clinical databases are kind of a bit of a mess, but the main thing is that they're not standardized. So a computer cannot use this very easily to do this kind of training. So what you will start to see now is that there's these huge associations in some ways. So you can see talks from Eric Topol that says like, we looked at 1 million ECGs and we looked at 1 million retinas, and based on these 1 million retinas with a retina picture, we can predict your coronary artery disease. Yeah, that's fine. That's the same as we know that ejection fraction very much correlates with outcome for large trials, for large cohorts, but an individual patient, I mean, ejection fraction is not always that useful. So, and in that sense, it's exactly the same things that we might have here. So what I think is much more important is that you really have to go towards, okay, we need to see where and how we work in clinical practice. Can we find help from these techniques? And so this is kind of a very simplified scheme of how you can look at the kind of flow of a patient through the hospital or through your practice. It's like the patient comes for whatever reason. It's like either on themselves or for follow-up of whatever. What you do is you acquire data. You do an echo, for example, and based on these echoes, you do measurements. And these measurements, which is a simplification of the echo itself, these measurements you then currently use in order to try to get an idea about your patient. And you do that by combining all the measurements that you have. And what is also very important is you interpret this with regards to other patients, with regards to guidelines, with regards to cohorts. Is this patient looking like a hypertensive? Is this patient looking like having coronary artery disease? So this is the way that you explicitly or implicitly in your brain do. You take data, you try to compare it to what you've trained for, so what you learned during your training, what you know from the guidelines, or what you know from experience. This part is the thing that you get better on. The older you get, the more patients you've seen, the better you get on this, comparing to what you've seen before. And based on that, you can make a decision, which could be, I need to do an intervention, the patient can go home and come back in 6 months. Or it could also be that you say, like, look, sorry, I don't have enough information, I can't make a reliable decision, go for an MRI, for example. So that could also be the case, and then you re-enter there. So now you see that there's all these different stages. So we have at the one hand taking a good echo. The other hand measuring strains or ejection fractions from it. The other hand is like taking all this data and look at the patient, compare the patient to a population, make a decision based on evidence from trials. And with all of these, actually, there are potentially tools that can help. So I'm not going to go in detail, but what you start to see now is that, for example, there are already ecosystems, especially some of the small manufacturers, but the big ones are doing there also, that help you in doing the echo. So you get the probe, you put it on the chest of the patient, and you see a red or a green light that says you have a good four-chamber view, yes or no. Or it's foreshortened, yes or no. So it really helps you in guiding to get to the best images. So this makes it faster, or at least makes it better or easier for non-trained people in order to do this. And you standardize more also the quality. So that's a good way. This is using these artificial neural networks. So then, of course, getting then data from the images, this is also something that nowadays you see more and more, and this is what currently the manufacturers are trying to sell you as artificial intelligence, but in the end it's machine learning for feature extraction, that is what it is. So which means that you can do automated measurements. You can here see some automated measurements of left ventricular function in the sense of thickness and diameters. You see automated delineations of Dopplers. You see automated volumes and ejection fractions. And this is again using these deep neural networks, or using deep learning, and this works actually very well. Because this is also very confined. So you can ask 1,000 cardiologists to measure one image, and you have these things. You use that for training, and there's not so much variation. Like there's a little bit of variation in the contour of the endocardium, but it always looks like an endocardium. It's not so very, very different. So this is starting, this is coming in the next generation. Now you have to pay a lot for it. In 5 years, this will be standard in your machines, and then this will be there. Now the next step is, of course, trying to understand, trying to diagnose this patient, trying to put a label of disease on it. This is much, much more tricky. And here is a study where they said, like, okay, let us try to recognize hypertrophic hearts. And they put a bunch of hypertrophic hearts, a bunch of non-hypertrophic hearts, and they say, look, we are very, very accurate in looking at the hypertrophic hearts. Indeed, they were. Except when you look at this publication and you see this image of the normal heart, and sorry, but this is not a normal heart in the middle. Everybody of us sees immediately, well, it's obviously not a hypertrophic heart, but it's certainly not a normal heart. The problem is here, they only trained for recognizing hypertrophics. And if you then say the other ones are normal, of course your patients are going to die if you don't treat them and don't see them. So this is very tricky. Here again, what you trained for is extremely crucial if you use this type of techniques. Now there are actually other ways also. So what we actually can do is we can try to use kind of machine learning techniques. In this case, mostly not deep learning, but potentially it might be. But the main thing is that we do here try to replicate this last stage of how we interpret images, which means data integration. So find ways that we can put imaging data, a lot of imaging data, complex traces, for example, together with labs and drugs and things that we know, and try to integrate that and use this to compare patients. So to position patient, is this patient more hypertrophic? Is this patient more dilated, or more this or more that? Really try to replicate by the machine what we do in clinical practice. And then we actually have a gradient also, because this is also crucial, because in most of our guidelines, we have cutoffs. And actually, this is one of the biggest problems of guidelines. If they say, look, under 16% of strain, that's abnormal. What do you do with a 16.5 or 15.5, or a 15 and an 18 maybe even? Like, sorry, it is not dichotomous. It could be in certain trials where you really take kind of extreme patients, but reality is continuous. So you have to try also to put a way of discontinuity and really in the continuous spectrum towards disease, try to position a patient. And then, of course, based on that, it could be that there's a risk associated, yes or no, depending on where you are. And then this, again, can be, if you have the knowledge, try to look at trials. And here, again, we can try to use machine learning there. And this is what we have here. So these come back to our hypertrophic patients. So what we actually do is we take the data from these patients. So we take the strains, we take the Dopplers, we take the full traces. So I want to look at patterns. I don't care about global or maximal systolic strain or things like that. I'll look at the strain patterns. And what we try to do is position patients which have very similar strains and clinical values and blood pressures. We try to put them close to each other. And the more different they are, we try to position them further away from each other. So this is what we call like representation learning. That's also a type of machine learning. And so what we end up with is we end up with a distribution of patients where we hope that similar patients are at the same time, at similar positions, and that's what you see here. So here, for example, you see that hypertrophic cardiomyopathies and the relatives which are not symptomatic are kind of distinguished in some ways because they do have different strains and Dopplers and clinical information. And actually what we then also can say is like, okay, but what is different? We can say like, look, in the strains, for example, are the HCMs, they have, or at least the most extreme of them, they have an obstruction. Or they might have a septal flash if you're looking at some other kind of thing. So you really can ask the computer then, it's like, why did you position these patients at different places? Show me the strains, what are there, and you really can physiologically interpret this. And then the nice thing is that you also can compare this to others. So you see here the really healthy controls. Of course, a lot of the relatives are in healthy controls, but many which are, for example, genotype positive but phenotype totally asymptomatic still have abnormal strains, for example. And this way you can look at this. Or hypertensive compared to HCMs, you see also there is overlap. And this is actually the spectrum of disease. There is overlap, but there are also quite some differences. And so this way we can really recognize groups of patients and clusters of patients rather than that we need to look at dichotomic kind of differences. And let me go here. So for example, also what you can see is then when you look at these, so we see HCM patients are kind of quite distributed, but only the ones that are here have late enhancement, for example. So late enhancement, while we didn't use it for learning, actually is associated with changes in deformation, Dopplers, and clinical parameters. So this, of course, makes a lot of sense, and this also helps you to show and interpret this kind of things. And this way, what we now do is, instead of these images, which I told you, they look very, very similar, what we now let the computer do is position these, and you see now that all these patients, you see that they are actually positioned with severity. And so you really can say like, okay, the patient that is here is clearly much more severe than the patient that is there, and you use this input data and you can try to interpret it. Is this useful? I mean, I don't have time to go in detail, but here, for example, something that I really, really like, this is a study that we did in pediatric dilated cardiomyopathy. And in pediatrics, I don't know if there's pediatric cardiologists here in the room, but what they know is that diastolic function in kids is very, very difficult. And you can kind of see that. So when we look at the aortic and the mitrals, what you see is that the E wave, even a restrictive E wave, doesn't look restrictive at all in kids. So you cannot use the typical things that we use in adults for kids. But on the other hand, what you do see, and that's what I said here, you do see that the ones which are severe and need a transplant are going to die. You see that they have these very late, rounded aortic profiles with very large isovolumic contraction times and very short isovolumic relaxation times because they have elevated pressures. And what they also have is they have very, very long pulmonary vein reversal flows. So a lot of the physiology makes sense is because we translate some things that we know from one side to other side. We say, it doesn't work. No, it doesn't work because we're not looking at the right things. And this can help us actually pointing towards some of these things. Or even ECG phenotyping. Here we use this HCM cohort where we really can look at high risks. But at the one hand, we have high risks with, for example, an outflow tract gradient. On the other hand, you have high risk with just low GLSs. Actually, based on the ECG, we can already get some information there also. So to conclude is, I think, machine learning and artificial intelligence is going to be the thing for the future. The thing is, we need to see what we use for what. For helping us to get better images, yes, this is coming. for helping us to do the tedious jobs for us, which is like the delineation or the strain calculation. Yes, this is coming. This will be in the coming years in your machines, and the companies are doing that for you. For clinical decision making, it's a little bit more tricky. It's like a lot of things what these big companies are saying, it doesn't work that well when you start really thinking about it. But if you do it in a physiological way, thinking about how it fits in clinical practice, actually the computer can help us suggesting something like, look at this. As like, for example, in the guidelines, there's currently, if there's apical sparing, think about amyloidosis. So this is the same thing. So the computer will tell you, will use the strains, will use the Dopplers, will use the images, will tell you like, this looks a little bit suspicious. Look, it might be in that category, and then it's up to you to do the further things in order to do that. Thank you very much.